Well, thank you for joining us for another episode of Family and Community Focus. Today we're going to be talking about the opioid addiction and opioid crisis. And with me is Dr. Richard Blondell, who is Vice Chair of the Addiction Medicine, Professor in the Department of Family Medicine at State University of New York at Buffalo and the Jacobs School of Medicine and Biomedical Sciences. Thank you for joining us.
You're welcome. Thanks for having me.
The opioid crisis or the opioid situation, that kind of stuff, there's they're calling it an epidemic. What are your thoughts on it? Is it really an epidemic?
Well, at least it's an epidemic in relation to the number of deaths that are associated with the use of opioids, which has now overtaken automobile accidents as the #1 killer of young adults. So deaths from automobile accidents was the #1 killer since World War II or before. And for the first time, another problem has come up to take its place. So if you're looking at deaths alone, we'd consider that an epidemic. But if you look at also overdoses that don't result in death, the number of people who are addicted to drugs, the crimes associated with what people need to do to get the drugs, all those are at epidemic proportions. Usually we reserve the term epidemic to infectious diseases.
Right, right. Yeah, I think that's why some people, I don't think it's a questionable thing. I think it's reached it there. The root causes or the causes of it, and why are we facing this epidemic?
We're facing this epidemic today because of several things. #1, in the late 1990s, pharmaceutical companies began to promote prescription opioids heavily. Prescriptions were then written by physicians who were trying to follow guidelines for reducing pain, often associated with patient demand, the third thing. The fourth thing is that these prescriptions were filled at pharmacies without any kind of thought given to the quantity that's being prescribed. And it was all financed by health insurance dollars. So those people who were prescribed these narcotics filled those narcotics usually with money associated with their private prescription plan or Medicare and Medicaid. And then some of those pills ended up being diverted to the illicit market where others could take them. So even the people who weren't directly exposed to a prescription opioid could get them with 1 or 2 degrees of separation from the original prescriber.
It sounds like there's almost 2 variables in there. One, somebody wanted to do good by people in pain. Another one is some of the people who were making the opioids.
Well, there's 6 variables. The pharmaceutical companies, the doctors, the patients, the health insurance companies, and the pharmacies.
So it's a little eclectic in how it came about and how it's actually probably perpetuating itself.
That's correct.
Is it getting better or is it getting worse?
It's not getting worse, but we have a little ways to go before it starts getting better. So the problem is kind of leveled off now, but we need to go back to basically how these medications were prescribed in the late 80s and early 90s, more judiciously, which means we're going to have to cut our prescriptions down by 4-fold to get those levels back.
There's the issue of women who are pregnant, who are addicted to opioids and taking them. We've seen it, fetal alcohol syndrome and stuff like that. How is it working with the opioid issue?
Well, with the fetal alcohol syndrome, women who consume alcohol put their developing children at risk for facial abnormalities and mental retardation. So alcohol has a direct toxic effect. Opiates not so much so. So the opiate in and of itself does not cause all that much physical harm, not the way, say, cigarettes or alcohol does. But it creates a whole host of problems. So what a woman would have to do in order to get money to get the drug. So sometimes they do things that they're not too proud of doing.
Right.
And then how they use the drug, once they're injecting the drug, then the route of administration, so the injection itself is often what causes the problems with infections that lead to the heart valve or other sorts of problems. And then the other thing that happens is the effect on the developing fetus, which becomes accustomed to the opioid, so that following the delivery of that baby, the baby may go through opioid withdrawal, which is often treated in a expensive neonatal intensive care unit.
You know, I'd be honest with you, it makes a lot of sense, but I haven't thought about it that much, about the part about the secondary behaviors, or the attributing behaviors that go with it. You're mentioning some risky behaviors that may partake in and all that kind of stuff that are maybe areas that people don't think about with people who have these kinds of addictions.
Right, so it's the criminal behavior, the disruption of family function, jeopardizing employment, and then exposing them to risk factors such as hepatitis C and HIV.
Yeah.
And so those are really where the problems.
And if you don't get proper nutrition all the way along the line.
Correct. If your primary goal on any given day is to get a drug, and your nutrition then becomes secondary, so that causes a problem. But the drug itself, the opioid itself, not that much of a problem except for neonatal abstinence. It's all the other surrounding behaviors and problems that are the big issue.
I'd not given that, to be honest with you, I'd not given it that much thought. Not surprising though. Mm-hmm. It's something you would think automatically that's going to happen, but I don't think a lot of people do.
Here's one of the issues with the opioid epidemic is that people don't necessarily give it a lot of thought and think about this rationally. So actions are often taken on opinions, prejudices, ignorance, and that in part contributes to the problem. So when we have leaders who are misinformed or haven't thought this thing through, then they end up making decisions that sometimes make things worse.
And even the general public is subject to propaganda then, or some various things without knowing all of the facts or all the components.
So even if the experts are a little behind on knowing all the facts and so forth, then the general public who gets their information from the experts are even more at risk for misinformation.
Yeah. So the treatment for this, how have people generally been treated for the addiction, especially to women?
Well, for years and years, the traditional treatment of addiction was abstinence-only behavioral therapy. And it worked maybe 20% of the time in being able to get people to get off of drugs and stay off of drugs. And that's about the best they've been able to do. Sometimes in really good settings, you can get that number up to about 40%. Among professionals, like physicians and airline pilots, you can get that up to about 90%. But typically, we're in the 20 to 40% range success with abstinence-only behavioral therapy. So what do we do with the other 60 to 80%? Well, we have medication-assisted treatment. So we prescribe medications to individuals to help them change their life. So we may either prescribe methadone in a federally licensed methadone clinic, or buprenorphine, which is brand name is Suboxone, in an outpatient setting. And that becomes a substitute for the drugs that they're using illicitly. Once we stabilize their illness medically, then that gives the behavioral therapy a little better chance at working.
Is it real hard, and I imagine it probably would be, for the people to kind of wean them off of the substitute, whatever you're using?
Well, that's another point. So people say, well, we're just trading one drug for another, which is true, but you trade not only one drug for another, but you trade the psychosocial aspects of that. So if somebody's using heroin, they have to do terrible things to get money to buy heroin. They have to cook it up and inject it, which has its own risk factors, and then they're at risk for hepatitis and HIV and heart valve infections and whatnot. So you trade all that in for things like methadone or buprenorphine, and those other problems then can be addressed. So they often will stop the criminal behavior, they'll stop the risky behavior, they stop injecting. So you mitigate all those other risks. So as a family doctor, I would say, well, that's a pretty good trade. Right. So addiction is a disease that can't be cured, like appendicitis or strep throat. So you got strep throat, give you penicillin, you're all better. You got appendicitis, you do an operation, take out the appendix, you're all better. Addiction is not like that. Addiction is like diabetes, high blood pressure, asthma. So we have treatments for those. We can give you inhalers to treat your asthma, to help improve your life. We can give you insulin to help treat your diabetes, but it's not like at some point in time we're going to take the insulin away. So we would take the insulin away or the asthma medication away if we could cure it.
Right.
But we can't. So likewise with addiction, we can't cure it. These medications help to control it and help to blunt some of the negative consequences. Now, some people can then transition to an abstinence-only approach and get off the medication, and that would be a good goal. Some people, for whatever reason, cannot. Right. And so they may end up taking those medications for a long, long time. But at least so we have to individualize the treatment based on the individual.
So at least they'd be able to work, they'd be able to function without the other components of the risk factors of doing something illegal or illicit.
That's correct. So if we can get people who are unemployed doing illegal things to be employed doing legal things, go from not taking care of your children to being able to take care of your children, that's a good trade.
Yeah, I was reading, in preparation for this, I was just reading over a lot of stuff, looking at all even like the NPR stuff that's been going on, and the amount of impact it has in the employment circuit for individuals and the workforce, and how many people are our potential workforce folks from an economic standpoint.
Right. I had somebody who owned a small business here in Buffalo, and he had some openings in his company, and so he advertised, and in one day he had about 100 people or so in this room taking a test or whatever they do. And then he said that he was going to do a drug test on all of them. Half of them just got up and left. So right there, just the pool of potential workers, there's a lot of people in there who on any given day are going to test positive for drugs. And some employers, like this employer ran a machine shop, and he couldn't really have employees who were impaired with drugs operating dangerous machinery.
Right. We talked a little bit about how well this treatment has worked or hasn't worked. 20% of the time, it's probably something that people can, I don't know if kick's the right answer for it. What other options are existing or ways that we're seeing is being approached?
Okay, so women who fail abstinence-only treatment, let's just say women have a problem, they go into an abstinence-only treatment, like the typical 28-day treatment, and they come out and they stay away from drugs and that's it. Well, I don't need to see them. So typically I will see the people who have failed abstinence-only treatment. So it doesn't make sense for me to order the same kind of treatment that didn't work before.
Right.
So the idea is to try something different, and that would be medication-assisted treatment. Those people who have social supports and who haven't lost everything on the outside may do very well with buprenorphine, where they come to the office once a month, twice a month, and get the medication and maybe do a little counseling on the side. Those people who have more severe problems, so heavily involved in the criminal justice system, for instance, homeless, lack of job skills and so forth, they might do better on a more potent medication, methadone, for which they have to come to the clinic every day to get the dose. And methadone itself is a little more potent than buprenorphine. So we might pick a treatment related to the severity of their illness. It's no different than like people go down to Roswell Cancer Center for their cancer. So if you got a localized cancer, you might just have a little surgery and maybe a little chemotherapy or something, and that's it. Whereas if you've got cancer that's spread all over, the treatment is going to be more intensive.
Right.
Same kind of way.
Same concept.
Same concept. So instead of like early stage cancer, late stage cancer, you can think about early stage addiction, late stage addiction. And we have different treatments depending upon how severe the illness is.
I would think the support structure they have away from the clinic, away from everything like that, plays a real critical role.
The support structure is important in helping people. So people that don't have a home, don't have family, don't have a job, don't have important significant others, struggle more than people that have a place to live, have a job, have supportive family members.
Is the availability of information, or if you're working with individuals who may have a support system, how does information get to them? How is it best to be able to say, okay, you got the individual you're seeing, I'd imagine if there's a spouse involved, they might come and see somebody or something like that.
Correct.
There's children involved, and maybe even some family members
Correct.
be associated with that.
Right. In our outpatient office, I've insisted that when people come for their first appointment for the doctor to treat their addiction with like a Suboxone, that they bring a family member with them. And there's two reasons for that. One is we start giving them the medication in the office, and I don't want them driving home when they could be influenced by the medication that I gave them, but also to judge the depth of the family support that they have.
That probably helps you to be able to figure out. I mean, is there connections in there? Like, I'm just trying to think of other diseases or other things that people go through and the importance of the family structure and somebody there that could either make a phone call or get somebody to see somebody quicker.
Well, cancer is a good comparison. So people that are in the later stages of their cancer often dependent on other people who will cook for them, clean up for them, provide basically in-home care as people become more ill. So another analogy is diabetes. So if somebody has diabetes, they frequently have to alter their diet, and that affects how maybe meals are presented at home. So there may have to be changes. So if you have a traditional working class man who has diabetes and a stay-at-home mother, that stay-at-home mother may have to make different decisions in grocery shopping and food preparation because now an individual has diabetes. So same kind of deal.
So now, we're talking about individuals here, and I know one of the areas you're focusing on is the mother and the child, the whole family. What's happening with the babies, and how is that being treated? And
Well, traditionally, a mother who had an addiction, at the time of birth, the infant may be referred to as Child Protective Services, and a whole host of things happens after that. I forgot where I was going with this.
well, we're talking about the mother, the babies. And,
Let me start all right. So the babies become involved because they're often reported to Child Protective Services. So therefore, the mother might need to demonstrate that they are capable of having this child, and the Child Protective Services has to make a decision whether to keep the child with the mother or maybe remove the child and put them into foster care. So if the mother's on heroin, trading sex for drugs and doing bad things and so forth, unlikely that she may be appropriate to take care of this child. On the other hand, if the mother's involved with a buprenorphine replacement program, coming into the office, looking for work, then it may be appropriate to keep the child with the mother. So that's the other advantage that medication-assisted treatment has, is allowing the mother to stay with the child, and then education can be provided to the mother about parenting skills and so forth. So traditionally, judges have looked at just the urine. So if there's no drugs in the urine, the judge will say, okay, the kid can come back. If there's drugs in the urine, they say no. When in fact, the urine toxicology may not accurately reflect the quality of the parenting that mother is able to give. So there are some mothers who are fairly stable on, say, methadone, that occasionally will have other drugs, but for the most part is keeping it together. And then there are others who don't have illicit drugs, but they may have turned to alcohol, or still their addiction's not under control, so they still may not be very good parents.
And they still may be doing the risky behaviors.
Still may be doing the risky behaviors. So the whole thing about medication-assisted treatment, it gets us to look at the whole picture, not just what's in the urine.
One of the questions that probably you hear a lot is the baby addicted?
Right. Well, let's say the baby is born addicted.
Right.
Addiction is sort of a social term. It implies not only a physical dependence on the drugs, but also dysfunctional social behaviors. So criminal activity, not showing up for work, and so forth. Stealing to get money to buy drugs. So a baby may be born physically dependent on the drug, but not many babies are creeping out of the nursery to steal car radios to buy drugs. So those sort of criminal behaviors is what constitutes addiction.
Okay.
So the babies have what we call the Neonatal Abstinence Syndrome, NAS. And during that time, the baby may go through withdrawal, which can be treated with medication. And then following this, the baby's normal. So after the baby leaves the intensive care nursery, it's not out on the street corner trying to score a bag of heroin, you know. So I think that the term addicted doesn't really apply very well to newborns. And this kind of has a judgmental tone to it.
So it'll be a misnomer to characterize it. They're saying that they have a little dependency on it or whatever it is, but that can be weaned off of.
They have a physical dependence.
Physical dependence.
But they're not psychologically dependent, obviously.
What have you learned from the project you've been involved with?
What I've learned from the project is some of the overlooked things that are going in the lives of these women. We know that addiction is basically genetic. So if a woman has this addiction, typically someone in her family did as well, typically one of her parents. And so this woman was raised in an environment with drug abuse. And then all the things that go along with that. And one of the things that I found kind of surprising is the percentage of women who are physically and sexually abused as children.
Really?
Almost half. So now you take that woman who had drug-dependent parents, grew up in a dysfunctional home, was molested, started using drugs herself at an early age, and now is in her early 20s and is pregnant. That's not the same woman as someone who grew up in a loving environment. So, and that complicates our treatment. So that's why just giving them medication is the medication fixes sort of the physical part of this disease. It does not fix the psychological part. And it doesn't go back in time and remedy the damage that was done early on. And so that's why counseling may be important for these women, particularly as it relates to their sexual abuse issues. Now what typically happens is that they're given methadone and they go to a psychiatrist, and the psychiatrist gives them antidepressive medications. And a lot of times what I found is the women have never told anybody in the healthcare professions about their history of, say, sexual abuse. Because they've tried to kind of suppress it themselves.
Right.
And yet that's one of the things that seems to be gnawing at them and interfering with their ability to get better. So we have to address those issues. And early on, I just bought into the concept, well, they're all bipolar, or they're depressed, right, and they need this medication. And what was surprising to me is how far back in time you have to go to fix the damage that has occurred among these women.
And that's why you're such a strong proponent of not just the medical part of it, but the behavioral part of it, the counseling part, the therapy part of it.
Right, and it has to be gender specific. So the counseling needs of a woman who is pregnant or parenting a child under 5 are very different from older women, childless women, women who've already raised their children, and very, very different from men. So what we've done in our practice is have a support kind of group, an education group for pregnant and parenting women who are parenting children, preschool children, and they're separate. And they tell us is that they can address things in this particular group that they couldn't address in, say, a mixed gender group or a mixed age group. So because they have unique needs.
Right.
And so we have to have unique programs targeted for them. And to throw them into outpatient treatment programs just like for everybody else, and then wondering why it doesn't work is sort of what we're doing now. And we need to have more specific, gender-specific programs, I think, for these women to help them recover from all the other things that they've gone through.
Which is what your research has shown and what you're doing in practice.
That's correct.
Wow, believe it or not, our time has gone
Okay.
that quickly. I really appreciate you coming on and talking about this. There's certainly a lot more to it than we were able to touch on today. So thank you for joining us for this episode of Family and Community Focus, and we look forward to seeing you again.